It's my pleasure now to introduce our next speaker, which his name is Christian Kollmannsberger. I'm just going to say Dr. K. How about that? Dr. K has been a staff medical oncologist at the BCCA Vancouver Cancer Centre since February of 2004 and a clinical associate professor at the University of British Columbia since January of 2006. Dr. Kollmannsberger graduated from the Technical University in Munich, Germany, and received his clinical training in internal medicine, hematology, and medical oncology, mainly at the University of Tübingen. Is that how you pronounce it? Tübingen, Germany. Dr. Kollmannsberger's research is focused on genitourinary malignancies with a special interest in testicular and renal cell cancer. This includes phase 1, 2, and 3 clinical trials, the development of new therapeutic options, and investigation of mechanisms of treatment resistance. Nationally and internationally, he has contributed to numerous trials in the field of renal cell carcinoma as well as testicular cancer. So it's my pleasure to introduce Dr. Kollmannsberger.
So thank you very much for another invitation to participate in one of those patient evenings. I think it's a very important thing to do because the treatment landscape in kidney cancer has changed significantly over the last 10 years, and it's going to be even more complex in the future. And I couldn't agree more with what was just said, that patients need to be their own advocate, especially in our healthcare system. And the more you know about the disease and the more questions you ask, and the better you are informed, the more easier it will be to do that journey with yourself or with one of your relatives who suffers from kidney cancer. So I would like to give you a quick introduction in kidney cancer and say something about the background information, and then we talk about the available treatment options and how we give it, why we give it the way we give it, some side effects, and then a very small outlook on what the future may look like. So in Canada we see about 6,000 kidney cancer cases per year. That's not very much compared to the big ones, lung, breast, colon cancer and prostate cancer. And that also means that there's not as much attention on kidney cancer as in the other big diseases. And that is something why Kidney Cancer Canada is so important, because it is an advocacy group which speaks on behalf of our patients and has in the past been very instrumental to really bring all these new treatment options we have to Canada and get the government to pay for these treatment options. When we look at the incidence of kidney cancer by province, you see that in Canada we have a fairly high incidence of about 17 per 100,000, and you see that it's different from one province to the other. And in BC, which doesn't show here, but it's the first to the left, the first blue one to the left, it's actually the lowest in the country, and that has probably to do with the lifestyle in BC and other risk factors, as we will see in a few minutes. What are the risk factors? Well, a long time ago, occupational exposure to certain poisons like herbicides or solvents were the #1 risk factor. These days, it's smoking. And a lot of patients are always surprised when we discuss that, because smoking is usually associated with lung cancer, but a lot of people don't realize that smoking is the #1 risk factor for a number of other cancers as well. About 30 to 40% of kidney cancers are attributed to smoking. So are bladder cancers, gastric cancers, and a number of other cancers. And then there's a small group of patients who have what we call a genetic syndrome, so patients who have some kind of genetic abnormality which predisposes them to developing kidney cancer. And often you can suspect something like that if you have several cases of kidney cancer in the family, or if a patient develops kidney cancer at a very young age. We differentiate different subtypes, and you may have heard that. We often talk about clear cell renal cell carcinoma, or non-clear cell renal cell carcinoma. That is important these days because all the new drugs which we have and which we use have mostly been tested in this subtype of clear cell carcinoma, which is about 75 to 80% of patients we see. The non-clear cell patients, which comprises a group of patients with different subtypes, as you see here, papillary, chromophobe, oncocytoma, and others, it's a small group of only about 15 to 20% of patients, and they are less well studied. We still use the very similar treatments, but we know that the treatments are not as effective as they are in this clear cell population. How do we classify kidney cancer? Well, there are usually 4 stages, stage 1 to 4. The first 3 stages, stage 1, 2, and 3, are the stages where the tumor is localized and in the kidney or in the region of the kidney, and mostly those patients are primarily treated with surgery. And when the tumor spreads outside of the kidney, then we talk about stage 4. And common places where kidney cancer goes to are the lungs, the livers, the lymph nodes, the bones. That's where we often find metastasis. And once the tumor has spread, then usually the medical oncologist comes into play in order to take over treatment. What kind of treatment options do we have? Dr. Black has already alluded to some of them. We use surgery not only for localized disease, but also to remove the kidney, even if there are metastases and the patient is able to tolerate that. That has been shown to be beneficial. So don't be surprised if you get confronted with something like that. Targeted therapy, which we will talk in more detail about that. Immunotherapy is also something which we have used previously. Before we had those targeted therapies, the only treatments available for kidney cancer once the kidney cancer had metastasized was immunotherapy, and that was drugs like interferon and interleukin. Those were drugs which stimulated the immune system, and the thought was if we stimulate the immune system can get rid of the cancer. That didn't work very well. The drugs were associated with a lot of very, very severe side effects. And in the last 10 years, it has been used less and less. But, as you will see at the end of my talk, this is a field which is rapidly coming back with very, very interesting new drugs. Radiation therapy is something we use, particularly in order to treat local problems such as bone metastasis or things like that. Classic chemotherapy, as it's used in breast cancer or bowel cancer, does play almost no role in kidney cancer because we know that these tumors are notoriously chemotherapy resistant. It's really a domain of the targeted therapies and probably in the future of immunotherapy. And sometimes we watch patients, as do the surgeons. We know that kidney cancer is a disease which has a very broad spectrum of behavior. In some patients, where we know that the patient has metastasis, we can watch them for a very long time because they don't grow. And then on the other end of the spectrum, you have patients where the tumors grow very, very rapidly. It's not easy to pre-specify which patient benefits or which patient is a good candidate for that kind of approach. So sometimes you may go to your oncologist and you have a CT scan and he sees something, and if the patient has no symptoms and is doing otherwise well, the oncologist may just say, you know, why don't you come back in 8 or 10 weeks and we repeat the scan and see whether the tumors grow or not. And then you come back after 8 or 10 weeks and the tumors have not done anything. And the oncologist may say, well, come back in 3 months and we look at it again. And so you slide into this observation mode, which sometimes can be extremely beneficial for a patient and can last for years. What other treatments we use? Well, we talked about the removal of the primary tumor in the kidney. We also use surgery if a patient develops solitary metastasis, especially if the interval between the primary tumor and the metastasis is long. Then sometimes surgery is a very good tool to get rid of the tumor. Radiation therapy we discussed, it's usually used in very selected patients, and then we use the targeted agents. This just demonstrates you how rapidly the field of kidney cancer has changed in the last 10 years. If you look at the block before 2005, you see interleukin and you see interferon. And in the last 10 years, there have been about 6 or 7 drugs approved in kidney cancer. That's pretty unprecedented and has completely changed how we approach that. And I don't think it will end, because there's also already a new generation of drugs in the development, and they will most likely come out in the next coming years. So what is targeted therapy? It's a very fancy word, and it's called targeted therapy because it targets a specific mechanism in or outside the tumor, which we think is crucial and important for the growth and spread of the tumor. That's why we call that targeted. A tumor is driven by certain mechanisms in the tumor cell, and the targeted agents try to target the most important drivers of the disease, and by doing so, they try to shut down the tumor and prevent growth and spread. One of the most important mechanisms is the formation of new blood vessels, called angiogenesis. That's why these drugs are called anti-angiogenic drugs. That's the first group, and the second group are so-called m-TOR inhibitors. m-TOR is a protein in the cells which controls and regulates a lot of different things, amongst them again the formation of blood vessels. And as I said, there's many others in development. Why is the formation of blood vessels so important? It was recognized about 40 years ago that seems to play a very important role in the development of tumors, not just in kidney cancer. And for a very long time, this was the story of targeted therapies. They seem to work quite well in mice, but we are not mice. So only in the last 10-15 years, it really has made the transition into patients. And why is it so important? Well, if you have only a few tumor cells, they can survive by simply getting enough energy and nutrients and food. But as the tumor grows, the tumor needs more and more support and energy and sugar and all the other things tumors and cells need to survive. And those are very smart cells. Tumor cells are very smart. What do? They send out information to surrounding blood vessels and say, we need your support, grow towards me and support me. That's the formation, or the angiogenesis, the formation of blood vessels. And the more the tumor grows, the more blood vessels they need. And they grow uncontrolled blood vessels towards the tumor. So it was recognized early on that maybe if we shut that mechanism down, we can keep tumors under control. And that's what these drugs do. Those drugs interfere with the formation of these blood vessels. That's how we think they work. And there's a number of them now which we use. One of them is Sunitinib. Sunitinib is a pill, and we talk about that in more detail. Sorafenib is another one of those drugs out of that group. Pazopanib is another one. Axitinib. There's Bevacizumab, which is actually not approved in Canada for the treatment of kidney cancer, but it interferes in a different way. And then there are the so-called m-TOR inhibitors, temsirolimus and everolimus. Those are drugs which we have in Canada as well. So when we treat with targeted agents, almost all of them come as pills, which is very convenient for patients. It is important to know that there is a couple of very important things patients have to realize when we treat them with these targeted agents. It's a chronic treatment. We will keep the patient on those drugs as long as they benefit. So with these drugs, what we hope to achieve is that we can turn that kidney cancer in a chronic condition, which we treat on an ongoing basis as needed with different drugs, so that we can keep the tumor under control. And you heard from Jim earlier that he started his treatment in 2007, so 7 years ago, and we were able to keep things under control for 7 years by treating with a variety of these drugs. But they are a long-term chronic treatment. That's why the management of side effects and the management of treatment is so important to those treatments, because you can only get the maximum benefit out of these drugs if you are able to manage the side effects so that the patient can remain on treatment as long as they benefit. It's usually a treatment which is given as outpatient, so for almost no patient we need to admit the patient, and the treatment needs close surveillance, in particular in the beginning, so that we can manage the treatment and the side effects and prevent any bad things from happening. What do we expect from these agents? Well, we ideally want to shrink the tumor. That's what we call a response rate. We want to prolong the interval without tumor growth, progression-free survival, that's the medical term for that. And we want to prolong life, so the overall survival. And that's what we can do with these drugs. Can we make the tumor go completely away so that it stays away? Not in the majority of patients. There seems to be a small group of patients where we may be able to do that, but that's a very, very small group of patients. And we cannot predict whether that will happen or not. The problem with these drugs is they work quite well, but they all have potential side effects. So when we look at the two most common drugs we use in British Columbia, that's for the first-line treatment, so the first treatment we usually give patients, that's Sunitinib and Pazopanib, and you can see they sound kind of a bit similar with the nib in the end. They come out of the very similar group. They are oral pills, and they inhibit mechanisms which drive the formation of blood vessels. And what can they do? They have been shown that they are better in terms of tumor control compared to placebo or the old treatments we had. So they are able to shrink the tumor better and to keep more patients stable for a certain period of time. Unfortunately, they both have side effects. But in terms of quality of life, that seems to work fairly well. Most patients report that their quality of life is still quite decent when they are on these drugs. And we know that they can significantly prolong the progression-free and the overall survival of patients, which is significant. What are side effects? And this is something which is extremely important. And when you ever see the patient information on these drugs, there is an endless list of potential side effects. That has to do with the fact that everything which has ever been reported in conjunction with these drugs has to be in there. And there's a lot of side effects which may never happen and which a patient may never see. The ones I've listed here are probably the most common ones. I always tell my patients that side effects can happen, they don't have to happen. And we cannot predict whether a patient will develop side effects, and if yes, which side effects and with what severity. That's why it's so important to keep a close eye on a patient in the beginning so that we can intervene and change treatment early on so that no bad things can happen. One side effect which all of these drugs can have is that patients feel more tired. That's a very difficult side effect. Now, luckily, most patients don't have it severely, but it's a difficult side effect because there is not really a good remedy for that. There is no pill and no really good strategy to deal with that. Paradoxically, the only proven intervention for fatigue is activity. So I often encourage my patients, instead of being a couch potato on a couch all day, do an activity for half an hour, and even if it means that you have to sleep afterwards for an hour, and then do 2 or 3 of those kind of exercise units a day. That seems to be better than spending all day on a couch. All these drugs can elevate your blood pressure. So patients have to monitor their blood pressure. It's usually a fairly simple side effect because there's an endless list of blood pressure medication you can use, and there's not any special spin to this, so this can be treated like any other high blood pressure. Some patients develop a sore mouth. That again is something more difficult because it hurts and makes eating potentially more difficult, and we try to treat that symptomatically. Indigestion is also something a lot of patients develop: heartburn, indigestion, kind of a rumbly stomach. Diarrhea can happen. Again, something which we usually get under control with anti-diarrhea medication. Skin rash can happen. Skin rash or painful blisters on the hands and feet. That is something which needs special attention because, again, as Jim is an expert on that, it can be, if it's bad, it can be very, very painful. Now, I would say that ever since Jim had that in 2007, we've learned a lot about how to deal with that side effect. And I think the number of patients who had hand-foot syndrome the way Jim described it is these days vanishingly low, thankfully, because we learned how we better use these drugs and how to prevent these side effects from happening. This just shows you in what kind of percentage these side effects have been observed in the big trials. Nexavar is sorafenib and Sutent is sunitinib. Keep in mind that that numbers there, when it says 70% rash, that includes everything from developing one pimple to completely red skin. Okay, so all grade toxicity and side effects, they're all grades in there. So 70% sounds bad, but the majority of patients has a few pimples and things and not really anything worse. But as I told you, there's a long list of potential things which have been observed. So an important thing is how do the patients cope with side effects, and what do we do with side effects? So from a patient point of view, as I mentioned, side effects can happen, they don't have to happen. So it's something which we cannot predict and which we need to basically try and see how patients tolerate it. Every patient is different, so to conclude and draw any conclusions from one patient to the next one is very difficult because the profile of side effects may be completely different. Most of the side effects are treatable, and we have really learned over the last 4 or 5 years a lot how to manage these side effects. There's a number of medications which can help with a number of side effects. Things like high blood pressure is fairly easily treatable. And even if patients develop pain in association with the treatment or the tumor, that is something which we usually can cover quite well. So there's a lot of things patients can do to prevent or relieve side effects. And usually when I have a new patient, I sit down with them and we go through some of the most common side effects, and I tell them what they can do, and we have a patient information which lists things patients can do, and that ranges from keeping your hands moisturized to prevent skin cracking and dry skin, to regular mouthwash and teeth hygiene in order to prevent things like an inflammation of your mouth or skin cracking on your skin. So there's a lot of things which can be done, and I try to educate my patients as much as I can about these things, because it's always a cooperation between the physician and the patient in order to be able to best manage these side effects. What can doctors do if side effects happen? Well, we have a number of tools which we can use. There is a number of drugs which can help with side effects. So, for example, high blood pressure can be treated with blood pressure medication. There is the option of just stopping the treatment temporarily and giving the patient treatment breaks until the side effects disappear. We can theoretically lower the dose. I will say something about that in a second. We can change the schedule. Some of these drugs are given continuously. Sunitinib, for example, is given 4 weeks on, followed by a 2-week break. I look when a patient develops side effects, I sit down with the patient and we analyze the pattern of toxicity. If the patient tells me the first week was good and the second week was good, but the third week is getting difficult and the fourth week is really, really bad, then maybe a switch to a 2-week on, 1-week off schedule is helpful for that patient, because it prevents those side effects from developing. Or worst case scenario, we have to switch to a different drug if the patient really does not tolerate the drug. So as I mentioned, we have different options. How do we choose for an individual patient? And that is a bit difficult. We use different criteria. These drugs have slightly different side effect profiles. Are there any coexisting illnesses which we need to take into account? I think a lot depends on the experience of the treating physician. What the oncologist you have has the most experience with, because that is important. Experience will be extremely important to manage the treatment. Depends a bit on how well or unwell the patient is. The age of the patient occasionally plays a role. What other drugs the patient is on. So there's a number of factors which we take into account when we choose these drugs. Now, ideally, we would be able to determine a factor in the tumor, which would tell us this patient is best treated with drug A, or this patient is best treated with drug B. Those are called predictive factors because they predict whether a patient will respond. So that would be ideal, but unfortunately we don't have them yet. There's an awful lot of research going on which tries to figure out, can we predetermine which drug is best for which patient? And that will come. I think it's just a question of time. We're not there yet, but once it happens, it will greatly help us to determine the best treatment for an individual patient. Interestingly, and that's just kind of a remark, over the last few years, we actually observed that the patients who developed side effects seem to do better than those patients who developed no side effects at all. And that's a bit kind of odd, but I think it can be explained that we know that we need a certain amount of drug in the patient to achieve the best result. And it seems to correlate with the occurrence of side effects. So if a patient develops side effects, that tells me there seems to be a healthy dose of the drug in the patient, and then you can fine-tune the treatment so that the patient does not suffer too much from the side effects. But if a patient develops no side effects at all, that always makes me think, do I have the right dose or not? So side effects per se, you may see that your oncologist give a short smile when you tell him that you have side effects. That's just because he knows now that there is a good amount of drug in the patient. So I think there's a number of key factors for successful therapy management. One is the dose. You have to have the right dose. One is the treatment duration. You have to be able to keep the patient on the treatment as long as the patient benefits, and that has a lot to do with optimal side effect management. And only if all that comes together, then you have the optimal outcome for an individual patient, and we have to optimize all of these three areas in order to get the best outcome. One word on dosing and the occurrence of side effects. I always tell my patient that we will try to keep the dose as high as possible. And initially we thought we can give every patient one dose, and then that's fine. We know from classic chemotherapy, breast cancer chemotherapy, and bowel chemotherapy, that basically the more we give, the better. And it turns out within a certain framework that also applies to these new targeted therapies. So I always warn my patient, if I start them on one of those drugs freshly, that the first few weeks may be a bit bumpy, because I have to figure out what the best mix is in terms of dose and schedule for this individual patient, because I want to dose the patient just as high as I can in order to be able to get the best outcome. Can we combine these drugs? Oncologists are very simple animals. They have an active drug A and an active drug B, and oh yeah, we put them together and we have a lot better activity. You will see that in classic chemotherapy, with those targeted agents, especially the ones we have right now for kidney cancer, that doesn't seem to work very well. Number one, because the outcome is not much better than with a single drug, but the side effects are significantly worse if you put them together. So far we don't combine these drugs, we give them to patients sequentially, one after the other, rather than combining them. So we don't combine them. And unfortunately, as I pointed out, these drugs are able to maybe shrink the tumor and keep the tumor under control, but in a lot of patients, in the majority of patients unfortunately, even if we see an initial response, at some point the tumor escapes and starts to grow again. Why does that happen? Well, as I pointed out, these tumors are pretty smart and they seem to find a different way to stimulate growth. You can visualize that if you have a lot of traffic on a very busy highway and you block that highway, chaos breaks out and the traffic comes to a standstill. But over time, they will use the little side roads and the traffic will start to flow again. And we imagine that similar things happen in the tumor. Now you can argue, well then we block those side streets. That's exactly what we're trying to do by using a different drug and trying to reintroduce a response. So what do we do if they become resistant? or we can switch therapy. In some patients, we may increase the dose because we know that more dose may be better. Do we add another drug? We are not there yet, but that's a theoretical possibility. But usually, if it comes to a clear progression, that's what we call when the tumor starts growing, we usually switch therapy. And what do we have as second-line therapy? There are two drugs approved right now. One is called everolimus, the other one is Axitinib. Jim has experience with both of them. And those are drugs which mostly stabilize the disease. With Axitinib, we also see tumor shrinkage. With everolimus, not that frequently. But they are both able to keep the patient progression-free, again, for a certain period of time. And that certain period of time is very difficult to define because it's very different from one patient to the next, and we cannot really predict it very well. So when we look at the treatment sequence, we have first-line treatment, we have second-line treatment. It gets more difficult when you come to third-line treatment for a number of reasons. The most important one is because we have not been able to do the necessary studies to see which one is a good third-line treatment. So it becomes a bit of a question mark in the third-line setting, or beyond, of course. So are these drugs all available in BC? It's a very important topic, and I quickly want to touch on that. BC was the first province in Canada to fund these drugs back in 2006, 2007. Both Sunitinib and Pazopanib are now funded in BC. Temsirolimus is another drug which is for a smaller group of patients, which is also funded in BC, and Sorafenib is as well funded. Everolimus is funded, and Axitinib is funded. So we have all of them funded. However, can these patients have the drugs one after the other? That's where it gets a bit difficult, because Sunitinib, Pazopanib, and Temsirolimus are approved for first-line therapy. Everolimus and Axitinib is second-line therapy. But you can then not, in third-line therapy, go back and give one of the other drugs. There are countries where you can do that, in the States and lots of countries in Europe, but we cannot, based on the way we approve drugs. That's not possible. So there's a number of drugs out there, but we cannot just give them one after the other as we wish. So there are currently two lines of treatment funded in BC. There's no funding for third-line therapy or sequential therapy, and that has mostly to do with the fact that there are no larger studies published for that situation of third-line therapy, which we could use to justify treatment. Keep in mind that those drugs are not cheap. They are between $5,000 and $7,000 a month per patient. What do we do if we have patients who look for third-line options or other or beyond that? Well, sometimes private insurance pays for some of these drugs. Sometimes companies have so-called access programs where they give out the drug for free. And then participation in clinical trials is another option for patients. It's something which we try to do a lot, participate in clinical trials, because I think it's an extremely good vehicle to give patients access to drugs and treatments which they would otherwise not be able to have. Access to drugs is not a new problem. As you can see here, this is from the 1800s. And back then, they already had that problem with different drugs. We use them still, but not as much. How is the cost perspective? Well, these drugs are expensive, but we spend a lot of money on other things. So theoretically, the question is, can we afford it or not? I think it's a question to society how much money we want to spend on healthcare. It would be way too much to discuss that now, but it is something which we have to think about in the future, because healthcare is not getting cheaper, and we add more and more potential options. So clinical trials, I said, is a vehicle to offer other options. What are clinical trials? Well, they are research studies where we test new treatment options or methods or combination of drugs to look whether they are safe and effective and whether they are better than the standard treatment we have. The purpose of a clinical trial is to answer a specific question we have with regards to a new drug. And That is a very controlled process. A clinical trial may or may not benefit an individual patient, but I usually discuss clinical trials with my patients if I think that they are a good option for that patient. And just to give you an example, Sunitinib was officially approved in BC, correct me if I'm wrong, I think in 2007. But we had treated patients with that drug since 2005 because we participated in all the trials and access programs and research studies, and we were able to offer our patients the drug through that mechanism 2 years before it was officially approved. So they allow access to new drugs, and depending on what stage the study is in, we know more or less about the drugs. But if it is a large trial, then the large trial is usually done because the drugs have shown pretty promising results in smaller trials, and it's always worthwhile to discuss that with patients. And I would encourage all patients to ask actively about clinical trials because it is an extremely good vehicle to get access to other treatments. So there's a lot of questions about these new drugs and about these agents, and we have a little bit of time afterwards to discuss them. Some of them are listed here. Do patients always require therapy immediately? I alluded to that. That's not always the case. How long would a patient stay on these drugs? It's usually a chronic treatment. Can an individual patient take all those medications and work, travel, and carry on with their life in general? That depends, of course, a bit on how patients tolerate that drug. But I have a number of patients who go on vacation and trips on a regular basis. I even have patients who continue to work. So that is certainly possible. Are there any restrictions on exercising and diet? My simple answer to that question is always no. Whatever the patient tolerates, the patient can do. I encourage exercise, and I think a healthy, balanced diet is all a patient needs. Can patients take other medications when they are on these drugs? Yes, they can, but you should always discuss with your oncologist if you start a new medication, because they can have interactions, and it is important to recognize them so that it does not, so that unnecessary toxicity does not happen. Why is there no unrestricted access to these drugs in BC? We discussed that because we have a certain approval process, and we just simply have not been able to catch up and do all the necessary studies to get more drugs approved. And one question a lot of patients ask me is, can I stop the drug if the tumor is well controlled? Now that is a question which is difficult to answer because we don't have much data yet. It appears that some patients can indeed do that, and in some patients the tumor will stay quiet for a prolonged period of time. But a lot of these patients will eventually progress. Now, from what we know about these patients is that it seems that if you restart them on the same treatment as before, that they seem to respond as well. So it is something which can be discussed, but the usual way to give these drugs would be to continue a patient as long as a patient benefits. So what's next with these drugs? Well, as I pointed out, these drugs have significantly changed the way we treat kidney cancer, and I think they have significantly changed the outlook of our patients and the outcome for our patients. And there's a lot going on in kidney cancer. We have a lot of questions, as always in life. The more you know, the more questions you have. And a number of these questions are listed here, and we could have an endless discussion about that. All these questions have to be answered through clinical trials, and that's another reason why it is important for patients to participate in these trials, because that's the only way for us to really drive the field forward and find new ways to treat and to improve the outcome for our patients. What is the future? There is a number of new drugs in development. I think personally, and that's why I listed that here, because a lot of patients have heard about that now and ask me actively about is a new class of drugs which is called PD-1 inhibitors. PD-1 stands for programmed death 1, which is a protein which plays an important role in the regulation of your immune system. So that is what I alluded to when I said immunotherapy is coming back. We have a much better understanding of the body's immune system now, and we have known for a long time that somehow these tumors seem to be able to hide from the immune system. Because, I mean, the primary task of your immune system is to keep your body illness-free. So if the tumor grows, somehow it must elude the immune system. And it seems that this PD-1 mechanism seems to be one of those mechanisms which allows the tumor to hide. What they do is the tumors, they express something on the surface which makes the immune system believe that the tumor belongs to the body and is not something hostile. And what we can do with these drugs, we can interrupt that mechanism and basically make the tumor visible again to the immune system. And the results we've seen with these drugs so far, not only in kidney cancer, but in a variety of other tumors as well, they seem to be extremely promising. And these drugs are now in the final phase of clinical testing in large trials. And hopefully these trials will be positive, and we will see some of these new drugs in the not too distant future coming to clinic and being available for our patients. So I hope I have not confused you too much. If yes, then on a higher level. I think in summary, it's pretty simple. I think we have never had a more exciting time in kidney cancer, especially when it comes to the new treatments. And they have significantly changed how we deal with these tumors. And I think most importantly, they have significantly changed the outcome for our patients.